So welcome to this didactic session of the pediatric point of care ultrasound game-changing phenomena. This is an early recognition during serious illness. We have a number of astute colleagues that are presenting, and I'm going to go ahead and hand it over. All the doctors will be presenting. We're going to have Dr. Constantine, Dr. Chen, Dr. Chikazia, Dr. Leviter, Dr. Malia, and Dr. Riera. And with that, I welcome the panel and take it away.
Yeah, so thank you, Dr. Askar, for that kind introduction. So I'm Antonio Riera. I'm one of the ultrasound directors for pediatric emergency medicine at Yale University. Thank you for joining us for this session. And of course, we'd like to thank SAM for the opportunity for us to share with you some of our most memorable cases where POCUS really had a meaningful impact on the trajectory of patient care. So we're very excited for this session. You know, I have the privilege to present with some colleagues from other hospitals. So Erica's from Brown, Henry Chikeza is from Connecticut Children's Medical Center, and Lori Mali is from Columbia University Medical Center, and then Lei Chen and Julie Leviter work with me at Yale New Haven. And we're all PEM ultrasound faculty at our respective institutions. And it's really an honor for me to share this virtual podium with such a special group of pediatric POCUS thought leaders. I'm gonna jump right in here. We don't have, for purposes of this presentation, any financial or other conflicts of interest to disclose. So we'd like to make this a little bit interactive. So for those of you in the audience, if you're able to either log in through a website or through an application to Poll Everywhere, after the backslash, you're just going to put in Antonio Riera 374. And so, you know, that's the limitation for the unpaid subscription of Poll Everywhere. Sorry, I couldn't make it a little bit easier. I'm going to do it myself as well, because I know it takes a little bit to get in. So what we're going to do as you're logging in, I'm just going to give you a framework of the plan for the session. So we're going to present 6 actual cases of serious illness in children that we participated in the care of these patients. And they're going to be uncommon for one of 2 reasons. Either it'll be a case of a severe illness that presented with relatively mild symptoms, or we're going to present cases of severe symptoms where there was diagnostic uncertainty. So we hope to illustrate how precision medicine by POCUS helped clarify what otherwise was a pretty blurry picture. So the game plan is going to be, we're going to give you the history and physical exam. We'll give you the history. We'll give you the physical exam findings. And at that point, through Poll Everywhere, we're going to poll the audience and just get a sense of what the differential diagnosis might be. Then we'll walk you through the cases, integrate POCUS, the POCUS findings, go over some of the sort of key things to look at. And then at the very end of every case, we're just going to have hopefully what will be a fun multiple choice style board review question, just to hammer home a few take-home messages that we want to impart on you. So without further ado, we're going to jump right in. So case 1 is a case of long-standing chest pain in an adolescent. So this was a 16-year-old male who presented with pleuritic chest pain and shortness of breath, and the symptoms had been worsening for a couple of months. He was known to have mild asthma and seasonal allergies, and he actually had an ER evaluation a month prior with similar symptoms, and at that time had a normal EKG and a normal chest x-ray. On review of symptoms, he endorsed headaches, palpitations, cough, and some poor appetite. And he had been taking ibuprofen and albuterol throughout the course of illness without much help or improvement in his symptoms. And so this is the triage vitals and the physical exam. As you can see, everything is pretty normal for a 16-year-old. He was not obese by any stretch of the imagination, weight percentile 50 to 75%. The ED attending appreciated a well-appearing male in no distress without any cardiopulmonary or perfusion deficits at the time of the initial exam. Ooh, we already have some pull everywhere. Interesting. So what do you guys think? COVID is reasonable. Actually, this was actually pre-COVID case, but COVID is always in our differential now. Let's see, what else are we getting? Cardiomyopathy, I like that. I like what you guys are thinking. Cervical rib, ooh, out there. Lupus, I like that. Autoimmune, reflux, okay. Pretty good thoughts here. DVT, yeah, no tachycardia, but you know, ultrasound conference, so that. All right, whoever wrote conversion, you need to go to the penalty box, but I guess not unreasonable since the vital signs are normal. So, you know, per usual, EKG was obtained for chest pain. You can see here sinus rhythm, no ST changes to suggest any pericarditis. And, you know, the amplitudes overall seem normal to low normal. So nothing striking on this EKG. And then a panel of labs just for the duration of symptoms. You know, could this be more of an oncologic process? So the platelets were slightly low at 87, INR was slightly elevated, and the C-reactive protein showed a little bit of inflammation, but really not too helpful here. Of note, from a cardiomyopathy standpoint, had a negative troponin and a negative BNP. And then the X-ray came back. So the X-ray came back and it looked like this. This is the X-ray during this ED evaluation, and you can see the striking change in the cardiac size compared to the X-ray that was done for similar symptoms a month prior. So with this, we decided it was probably a good idea to do a focused cardiac ultrasound. So at our shop, to do a complete focused cardiac ultrasound, we get a parasternal long, a short, an apical 4, a subxiphoid, and an IVC as the minimum views for a complete scan. And we also encourage evaluation of the lungs for B lines and other potential abnormalities. And so this is what we found. This was around midnight to 1 o'clock in the morning when we put the probe on the parasternal lung access view. So we do it with the indicator to the patient's right over here. So the aortic outflow tract is to the left of the screen. So we're seeing the left ventricle here. And so when we saw this, it was essentially our jaws dropped down to the ground because we were not anticipating anything quite like this. And so not only is there a massive pericardial effusion, you know, with layering in front of the descending aorta, if you were to just stop it, do a still image in diastole where the LV is filling here, you can see ventricular collapse of the right ventricular wall, which would be consistent with physiology that we would expect with cardiac tamponade. Parasternal short axis view was subsequently obtained. And again, you can see a very large circumferential pericardial effusion. Interesting, the heart rate you can see even on this image is not above 100. So there's no tachycardia. So we know that the collection of this fluid happened slowly over time, and it didn't just happen over the course of a few hours. The operator here of note is doing a really nice job of sliding the probe from the aortic valve here all the way down to the apex to the papillary muscles. So a really nice job there on that. And that wasn't me, by the way. And then trampoline-like motion of the RV was seen in the apical 4 chamber view. So you can see this in-bowing here, again, massive pericardial effusion. And we made a little bit of note of some lesion that looked echogenic and round in the right atrium, which was a little bit concerning for potential thrombus or some other abnormality. So normal vital signs, symptoms going on for a couple of months, massive pericardial effusion, middle of the night. Our POCUS enabled us to expedite cardiology to the bedside. They did their own echocardiogram. They essentially confirmed similar findings for pericardial effusion. They actually noted right atrial collapse during systole, and they were concerned about a right atrial mass as well. Luckily, our patient did not decompensate during his time in the ED. We were able to safely transfer him to the pediatric ICU. There, a sedated pericardiocentesis was performed, and a pigtail catheter was placed and left in. A liter of serosanguinous fluid was removed, and cardiac MRI subsequently revealed a soft tissue mass in the subcarinal region, and follow-up biopsy was consistent with a sarcoma. So quite striking. And that's my doorbell. All right, so case question 1. What ultrasound function can provide additional confirmation to diagnose cardiac tamponade, in addition to RV collapse during diastole or RA collapse during systole? What do you think? Now, the E is going to be not the right answer. Spoiler alert. So I was always taught by one of my senior PEM attendings that having a pair of Depends available to you on shift is never a bad idea, because you never know when you're going to need them. But we would never encourage turning off your ultrasound machine. So the answer here is going to be D. It's going to be pulse wave Doppler. So with pulse wave Doppler, you can put the gate on the mitral valve and get a sense of changes in the mitral valve inflow velocity as related to inspiration versus expiration. And this is a little bit advanced, but just bear with me for a second. So these E waves are the peak amplitude. So this would be your peak amplitude and inspiration. This is your peak amplitude and expiration. And any delta greater than 25% is consistent with sonographic pulsus paradoxus and would confirm your suspicion for cardiac tamponade. And our patient had a delta of 27%. And with that, I'll turn it over for case number 2, Dr. Leviter, to give us her story.
Thank you, Dr. Riera. As Dr. Riera mentioned, my name is Julie Leviter. I'm coming from Yale University, and I'm pleased to present to you a case of acute onset chest pain. So this is a 15-year-old gentleman presenting with chest pain and shortness of breath, started this morning. No trauma, fevers, nausea, vomiting, or upper respiratory symptoms. So here are his triage vital signs. Just of note, the pulse is 80, respiratory rate is 22, oxygen is 96%. He is comfortable appearing, non-toxic. He has no JVD, and his respiratory effort is normal. He is noted to have decreased right-sided breath sounds. So using that pull everywhere, let me know what findings you're going to look for with ultrasound. Great, so I see PE, some absent lung sliding, COVID, lung sliding assessment, sliding. There's a lot of votes for lung sliding. It's always COVID. Barcode sign. All right, so a lot of you mentioned lung sliding, barcode sign, things related to pneumothorax. So let's talk a little bit about that. So in order to do a lung ultrasound for pneumothorax, we're going to use the linear probe in the longitudinal axis with the probe marker pointed toward the patient's head. We're going to have the patient in supine position, starting over the lung apex. We're going to slide down to the 4th intercostal space in the middle axillary line and start with a depth of about 4 to 6 centimeters, unless they have a larger habitus, so that you really get that pleural line in the center of the screen and get good resolution of it. So here's what we saw. So in the left lung field, you see the rib and pleura are labeled here, and the pleuris has some nice lung sliding along it, that sort of shimmering and analog appearance. And in the right lung, you see the rib and pleura labeled, and the pleura really doesn't have any lung sliding. It's pretty stationary appearing. So that's concerning. So back one slide. So here's another thing that we can do that was also mentioned in the word cloud, is we can use M mode to track motion over time. And in the left lung, we're getting that seashore sign. So that nice sort of appearance of the grainy appearance of the pleura and the field below it. And then in the right lung, we're seeing that barcode sign where there's no motion of the lung field. Now, the next thing that we're going to look at once we see that lack of lung sliding and the barcode sign that are concerning for a pneumothorax, we're next going to look for the lung point. And that's the point where the ventilated lung meets the non-ventilated lung. So in this slide, this isn't our patient, this is just an example of what we're looking for, where you see above the rib space on the left side, there's no lung sliding. And then on the right side, below the rib space, there is lung sliding. So this can give you an idea of where that pneumothorax ends. So in our patient, we did not see lung sliding And this is why. So you see in the chest x-ray that in the right hemithorax, there is no ventilated lung at all. This was a tension pneumothorax with left-sided shift, and it was highly concerning for tension physiology. But thanks to POCUS, management of this tension pneumothorax was already in progress at this point. So this patient, by the time this chest x-ray was obtained, the patient was already in the resus room, surgery was already at the bedside, and a needle decompression was already occurring. And so POCUS really expedited care for this patient. So this was a spontaneous tension pneumothorax, and we found that early recognition really expedited the treatment. A right-sided chest tube was placed, and this patient continued to have a pain and an air leak. So he underwent right-sided apical lung resection and mechanical pleurodesis on day 2 of admission. Then he had no further issues. So here's our next case question. Which of the following findings is most specific for a pneumothorax by ultrasound? And just take a moment to think to yourself. And the answer is lung point is most specific for a pneumothorax by ultrasound. And with that, I'm going to hand it over to Dr. Lori Malia.
Thanks, Dr. Leviter. As she said, I'm Lori Malia, and I'm from Columbia University, and I'm going to talk to you guys about the next case. So this case was a 4-year-old male who presented with abdominal distension and constipation. The mother reported that he had had no bowel movement for the past 10 days, and he had been seen on several prior occasions at different EDs for the same complaint and been given Miralax and enemas with no real success. And now they returned due to the patient had new onset onchoparesis. The mother reported that other associated symptoms included some very mild fatigue and maybe some poor weight gain over the past 8 months. On physical exam, you can see here the ED triage vitals were pretty much overall unremarkable. And the physical exam was notable for a soft distended abdomen that was mildly tender to palpation in the right upper quadrant with a palpable mass 4 centimeters below the costal margin. Otherwise, unremarkable exam. So based on this history and physical, what is the most likely diagnosis that you could share in the word cloud? Intussusception, constipation, nice constipation. We see a lot of constipation as PEM. Neuroblastoma, like it. Good. Wilms, yep. Great. All good thoughts. So based on the physical exam, next a radiology ultrasound of the abdomen was ordered to further evaluate. And it was read as pertinent for hepatomegaly, prominent hepatic veins, ascites, and gallbladder wall thickening with pericholecystic fluid. So due to the findings of the prominent hepatic veins and gallbladder wall thickening, a cardiac POCUS was performed to evaluate cardiac function. And like Dr. Era mentioned, in the earlier cardiac case, we also obtained the same views for cardiac POCUS. So we'll go through the views now. So the first view, this is the parasternal long of this patient. So typically in the parasternal long view, you can see the left atrium, the left ventricle, and a sliver of the right ventricle. However, you note in this clip that you see the right atrium because it appears very dilated, along with a dilated left ventricle that Antonio is pointing out. And this is abnormal. Also, I just want you to note that the orientation of this parasternal long is opposite from the prior case. And this is because at our institution, we evaluate the aortic outflow tract on the right side of the screen. So there's no right or wrong, it's usually institutional, but just a different example. Okay, so next, let's take a look at the peristernal short. So in this view, this is a cross section of the left ventricle. So here you can see the concentric shape of the left ventricle and evaluate squeeze. And here you see overall really very moderate to poor contraction of the left ventricle that indicates a degree of dysfunction in this patient. Here's the apical 4, and in this view, you can see all 4 chambers of the heart. And you note a significantly dilated right atrium and left atrium, along with a somewhat dilated RV and LV as well, which is also abnormal. And finally, the subxiphoid view is obtained. And here you can evaluate for effusion, and you can get additional views of the chambers. And you note here on this patient, subxiphoid, a small pericardial effusion that's noted by the arrow, along with a dilated right atrium. And a notably dilated left ventricle. And again, you can see the overall diminished function of this patient's cardiac function. So due to these findings on the ultrasound, on the POCUS, EKG was next obtained. Just going to give you a second to glance at it, but overall, it was notable for a number of different things. So the patient was in sinus bradycardia, had a normal access, and you can see that there were prominent mid-precordial voltages with biventricular hypertrophy. There's also ST abnormalities and T-wave inversions in the lateral leads. And then there's also deep Q-wave in the inferior and lateral leads that are abnormal. So next, a chest X-ray was obtained and showed a significant, was significant for cardiomegaly and pulmonary vascular congestion, which really echoed the findings that had been seen on the POCUS that was performed. Here are the lab results. Overall, the CBC and Chem20 were unremarkable with very mildly elevated coags. The troponin was also very mildly elevated at 23 at our institution, less than 20 is normal, and the BNP was elevated at around 5,100, which was abnormal. So the cardiac POCUS that was performed in this patient really led to an expedited diagnosis of cardiac dysfunction with concern for a new cardiomyopathy in this patient, and was able to prevent decompensation of this patient. The child was ultimately diagnosed with non-compaction cardiomyopathy, which is thought to occur due to failure of the left ventricle compaction during embryogenesis, which leads to distinct morphologic characteristics in the ventricular chamber that are seen in this diagnosis. So the patient was admitted to the ICU and started on a milrinone drip and diuretics. He underwent a cardiac catheterization that showed severe restrictive physiology, and there were plans and recommendations for a pacemaker and a heart transplant. But ultimately, the family declined these recommendations due to spiritual beliefs, and the patient has since been lost to follow-up. So question number 3 is, which of the following statements is false with regards to function assessment by cardiac POCUS? I'll give you a minute to look at it. And the correct answer is D, because visual assessment by ED providers has been shown to have very accurate estimates of cardiac function. And now I'll hand it off to Dr. Chen.
Good afternoon. Can you hear me all right? Thumbs up. I'm presenting a case of a 10-month-old male who presents from an outside hospital with signs and symptoms of shock. Previously healthy young man with 1 day of vomiting was seen at outside hospital and was diagnosed with viral gastroenteritis, received some fluid orally and was discharged home with an antiemetic prescription. The patient returned the next morning with recurrent vomiting that was again non-bloody nor bilious, but now he has a new symptom of respiratory distress. At the same outside hospital, concerns were raised for sepsis, bacterial pneumonia. They were unable to establish IV access, so an intraosseous was placed. Patient is placed on nasal cannula oxygen and transferred to our hospital for further management. So here's a photograph of the patient. The triage vital signs were recorded as blood pressure 70/30s, tachycardic to 200 with signs of respiratory distress, but the rate was 30, was on nasal cannula at 5 liters per minute, saturating 100%, afebrile, and a robust, otherwise well-nourished child. This is what I saw initially at 6:30 in the morning. He was ill appearing. He was minimally responsive. One thing that struck you, as it struck me at the time, that he has significant abdominal distension. So how do you think about a patient who has signs and symptoms of shock and seeming to have intra-abdominal pathology? What are the things that go through your mind at this time? It's not COVID, but yes, so intestinal obstruction and volvulus were certainly on top of our mind. Necrotizing enterocolitis, a little bit late at this age, but I'm not sure what SO stands for, but maybe small bowel obstruction. Perfect. Yes. Well, constipation, we wouldn't talk about constipation in this setting, but brilliant. Perfect. So, so those are the thoughts that went through our minds as well. There was concern for peritonitis. We consulted the surgeon fairly early in the disease course, and we performed a cross-table lateral where the film is shown here. As you can see, the pulmonary silhouette is relatively normal, no obvious signs of bacterial focal pneumonia, but loss of bare fluid levels throughout moderately dilated bowel. So again, going back, there's no PO everywhere anymore, but think about what other diagnoses are you thinking about. Volvulus usually presents with bilious emesis, and intussusception usually presents with current jelly stools and intermittent lethargy, with vomiting being only one of the signs. So this is a somewhat atypical presentation for either one of those two relatively common and serious conditions that we're concerned about. So we performed a bedside ultrasound to hopefully expedite the diagnosis. We use a curvilinear probe because his abdomen was moderately distended. Usually we start in the right lower quadrant, but these views are sort of at the mid right side of the abdomen. On the screen to your left, you can see the liver and the right kidney, and there is a targetoid lesion in association with some dilated loops of bowel. We switched over to a curvilinear, a linear probe to get better resolution. Certainly you can see dilated loops of bowel and a finding that's typical for intussusception. So this is an atypical presentation of what turned out to be ileocolic intussusception that was confirmed based on the fact that the patient had peritoneal signs and signs of sepsis. Instead of contrast NMR reduction, he was taken to the OR emergently. Again, the diagnosis was confirmed. Unfortunately, he required multiple resections and was left dependent on parenteral nutrition, had multiple courses of second and third looks, and there were subsequent complications from the surgery. He was left with a jejunostomy. But in fact, he has recovered. He has continued to grow fairly robustly. Eventually, he was able to transition to total oral feed. So again, this is a somewhat atypical presentation of a relatively common diagnosis, unfortunately with the outcome that probably is worse than we usually see. But I think POCUS certainly aided us in the expeditious diagnosis and management. Now I will turn it over to question number 4. Which of the following is associated with increased risk of intussusception recurrence after, so this is a typical child that received a air contrast reduction. What are the signs and symptoms that's associated with a prolonged or increased recurrence of, increased incidence of recurrence? If you don't like the answer, don't blame me. This is Antonio's answer. Yeah, I didn't like it either. I didn't think it was C. I thought it was like maybe, I don't know, length of symptoms or something. But
So it's
all
not
right,
my answer. It's just a systematic review and meta-analysis from
yeah,
2019. We're happy to share the link.
there's some systematic bias somewhere.
Yeah.
I will turn it over
Very
to case
skeptical.
number 5. I think Dr. Constantine's next. No, Dr. Darn it.
That's okay. Thanks, Dr. Chen. My name is Sandra Chikaiza. I work at Connecticut Children's, located in Hartford, Connecticut. Now we present to you case number 5, titled an appendicitis transfer. So before I start, I wanted to set a framework of like where this case occurs. So this is pre-COVID. This is an overnight shift that I came to take over of this patient from one of my colleagues. And it's a typical winter pre-COVID where basically everything is falling apart in the department and you're coming in to kind of take over the disaster zone. So we have a patient, she was a 16-year-old with appendicitis that was diagnosed by radiology ultrasound at the outside hospital. And at that outside hospital, she presented with abdominal pain that was associated with nausea and vomiting. She also complained of some chest pain that was associated with intermittent palpitations. However, she had no shortness of breath and was afebrile. On a previous note, like she was evaluated for this chest pain about a week prior to this original presentation. And chest pain was thought to be secondary to reflux. And as a result, she was started on the reflux therapy that she reported being on. So she was consequently transferred to our institution. The first physical exam that was performed by one of my colleagues. So in her vital signs, as you can see, overall low pretty much stable. Blood pressure 1/75, pulse is 96, respiratory rate is 20, O2 sats is 99% or more, and she was afebrile. The overall exam, she was described as uncomfortable appearing, and the other remarkable finding on her physical exam was diffuse pain, exquisitely right lower quadrant, and also displays some rebound. So based on the information that I've given you so far, what would you do next if you were going to come and take over this patient as your colleague is signing out to you? Call a surgeon. It's always good to call for a consult. Ultrasound. Yes, we are in a ultrasound talk, so that's always a good. Pregnancy sets, it's always a good call. CT abdomen. So all those are, it shows sort of the breadth of everyone's, different management, which is one of the reasons I love, ER. We have different approaches. So what ended up happening, so there was a repeat right lower quadrant ultrasound that was performed by the radiology, where a normal appendix was demonstrated in our institution. However, there was a large amount of free fluid in the abdomen and pelvis, and the dreaded line was seen in your board, which says clinical coordination is advised. At this time, when the patient was also assessed, she started complaining of that chest pain that she reported before. So the provider decided to get an electrocardiogram, decided to get a CT scan, as some of you suggested, and started to get some labs as well. And that's essentially when I came into this play. I was given the sign-out on this patient, and I was taken a part of this patient's care. So the first thing we got is basically a CT scan of the abdomen pelvis, which is remarkable, as you guys can see. That's a large amount of free fluid in the abdomen. Within it, they were able to see that it was a normal appendix, but they were just saw this large amount of free fluid the cause was undetermined. And essentially, again, it was like clinical coloration advice again. As I mentioned, she started complaining of this chest pain again. So therefore, an EKG was performed, and this is where things started to change. So as you can see in this EKG, there's diffuse low voltages and ST changes, as well as some frequent PVCs that you're seeing there. So naturally, since we're in the business of ultrasound, the next thing that was performed was a bedside echocardiogram. So the first view you have on the left side of your screen is just like sci-fi view. So essentially, is where we're trying to see if there's a presence of pericardial effusion. And I apologize, it's a little darker, but there is no pericardial effusion seen on this view. The view on the right side is a parasternal short axis where you see the squeeze of the heart, and you can tell that's not a good looking squeeze. So this then triggered to get more like specific labs, essentially added some cardiac and inflammatory markers. As you can see there, so her white blood count was overall normal at 5. Her H and H were a little low on the lower end. Lights were normal. AST was slightly elevated at 93. But more importantly, troponin was elevated at 6.63, a BNP of almost 3,000, and the CRP was only very mildly elevated at 0.67. So essentially, from the bedside echo, we can recognize that the patient has been in heart failure throughout this point. And this is sort of the slide that hits home for me the most, is that while she was in the emergency department, her vital signs were overall stable, despite being the fact that she was in heart failure. As you can see, she probably came in around like 9 p.m. And just around like 1 or 2 in the morning when I was coming in shift, her blood pressure went on the lower side, but still was fine, and her pulse was fine. And if you see the last blood pressure is 125/4, that's after I called the cardiologist. As you can imagine, after I had my bedside echo that showed poor function, I decided to wake up my cardiologist at 3 or 4 in the morning. She reviewed my images and decided to quickly come to an institution where there was a formal echo done, and the ejection fraction was 15, and it was decided to start up the patient on pressors, and the patient was then transferred to the PICU. So in this case, as I mentioned, our POCUS definitely expedited echocardiogram, which confirmed the left ventricular dysfunction that was initially assessed by our exam. Basal pressures were initiated, and the patient was expediently transferred to the intensive care unit. Her final diagnosis ended up being myocarditis with severe cardiac dysfunction. However, no clear etiology was confirmed. They ran every single test possible on this patient, and nothing was found. Fortunately, at the 6-month follow-up, she had regained normal ejection fraction, and then from then on, she was followed. It was recommended every other year. And then leads to case question number 5. When considering an acute appendicitis diagnosis by ultrasound, which of the following statements is true? So I'll give you a few seconds. And the answer in this case is B. Discordance between ultrasound findings and the clinical exam is common with misdiagnosis. So I hope you enjoyed this case, and I'm going to hand it over to Dr. Erica Constantine.
Thank you so much, Dr. Shikeza. Our next and final case is the story of a 12-month-old male who presented to an outside hospital with the chief complaint of not acting like himself. He had a few days of kind of upper respiratory symptoms, some rhinorrhea, had been a little bit fussy. He had some diarrhea, but the real reason that his mom presented to the outside hospital that day was because he just wasn't acting like himself. So on presentation to the outside ED, he was found to have a heart rate of 220, after which time a diagnosis of SVT was made on the basis of an EKG very similar to the one that you see there. It took 3 doses of adenosine to cardiovert this child. He was then fluid resuscitated and transferred relatively expeditiously to our center, which is a tertiary care children's hospital. So on arrival to our emergency department, this child was very ill appearing. He was crying, he was inconsolable, and he had extremely poor perfusion with a cap refill of 4 to 5 seconds. Of note on his physical exam findings, his vital signs, you see he was completely afebrile. And surprisingly, he still had poor perfusion, but his pulse was normal at 150. Now, as you can imagine, in a pediatric child who is screaming and inconsolable, your physical exam, other than what I've mentioned, basically goes out the window. So you can't hear anything on the lung exam, you can't hear heart sounds, you can't palpate the belly because it's too rigid from crying. So we didn't really have much other than what I mentioned in terms of physical exam findings. So with those findings, we whisked him to our trauma room where we had this chest x-ray done fairly quickly because the tech happened to be hanging around our ED at that time. And I'll just let you look at that for a minute and we'll go to the next slide. And I'd love to ask you, on the basis of the history and physical exam and on the chest x-ray that I showed you, what do you think is the most likely diagnosis? 12-month-old male, couple days of URI symptoms, recently cardioverted for SVT, transferred, sick looking, CHF, bronchiolitis, lots of heart failure, pneumonia as well. These are all great answers, lots of CHF. So looking at that chest x-ray, to me, that is one of the least useful chest x-rays that I have encountered. There was a ton of overlying artifact. I really couldn't see the lung fields very well. Couldn't see the heart shadow. The kid was screaming, might have been an expiratory film, not very useful. And in my shop, whenever there's a child with undifferentiated shock, I think the most important tool you have to remember is the ultrasound. And I usually ultrasound first when it comes to undifferentiated shock. Now, in adults, the algorithm for undifferentiated shock using ultrasound is a little bit more complex than in the pediatric world. In pediatrics, we can simplify it to a quick mnemonic, which we call HIP, and that stands for heart, IVC, pleura and lungs, and peritoneal fluid. So with that, the first view that I obtained was a parasternal long view of this child's heart. And in our institution, we place the index marker to the patient's right side. So you can see the apex is on the right of your screen here. And what I'm looking for is what is the overall global systolic function. Now, it's not horrible like some of the other images we've seen today, but what I'm looking for really good global systolic function is what that anterior leaflet of the mitral valve looks like. And in a normal, healthy 12-month-old male, that anterior leaflet of the mitral valve should be hitting the septum. And in this case, it's just not quite hitting the septum. Next slide. So our next view is the IVC. And what I'm looking for is normal respiratory variation. And in this child, you can see some motion from breathing, but you're seeing absolutely no collapsibility. So this is what a plethoric IVC looks like. And already, given the heart findings that we've seen, that is an obstructive shock or fluid overload. Now, the last view that I obtained in this child is looking at the lung fields. And in children, we can get away with using the linear probe. And that's because the kids have very skinny chest walls, and the linear probe provides really good resolution of the lungs. And what you can see that's most notable here is that you can see multiple B lines across several rib spaces bilaterally. And these are the posterior lung fields that I'm showing you, but what's interesting is that this child had B lines everywhere in all the lung fields. So based on all of this, we basically came to the diagnosis of fluid overload, and that's shown by mildly decreased cardiac function, a plethoric IVC, and multiple B lines that are suggestive of alveolar interstitial disease. And our acute management was to give a dose of Lasix, and within a couple of hours, the patient had 800 cc's of urine output and an improvement in the respiratory rate. And the child was then admitted to our ICU for further care. And I think the take-home point for this case is twofold. Number one, the chest x-ray is not as useful as you could imagine, given how often we use it in the trauma room. I feel like we order x-rays of the chest because we seem to order it in everybody, but it actually has limited utility in a case like this. And what you should remember from this case is in undifferentiated shock in children, your primary tool should be the ultrasound to bring it to the bedside, look at the heart, look at the lungs, look at the IVC, and you'll often be able to narrow down your differential quite quickly. Next slide. So with that, question number 6. Regarding lung ultrasound in children, which of the following statements is false? And I'll let you read for a minute. And the answer in this case is C. Lung ultrasound does not easily distinguish COVID-related disease from bronchiolitis. In fact, COVID looks very similar to bronchiolitis on lung ultrasound. And it's often used in the adults, especially because they tend to have worsening disease. It's often used as a screening tool in COVID-related disease. And basically what people are looking for is bronchiolitis type findings. And with that, I'm going to turn it over back to Dr. Riera for a summary.
Right, so sorry to jump the gun there, Dr. Constantine. So we're hoping that with this presentation, some of these POCUS cases will light a fire for you to incorporate this modality into the acute management of your children that present in the emergency department. It certainly lights a fire for us, and there's some key take-home points that we want to impart on everybody. So undeniably, in all of these cases, POCUS was a game changer in the trajectory and in the emergency care of all these children and their families. And we've shown, we actually had a tough time picking cases, but with the cases that we selected, we have shown definite instances where significantly abnormal POCUS findings preceded any vital sign decompensation. And there is the hope that with POCUS, we can improve the precision in our emergency care, as it'll help narrow your differential diagnosis. And we encourage you to integrate this application early when there are severe or unexplained symptoms in children. And I think we have a little bit of time to take any questions that may come up. And again, thank you so much for the opportunity for us to present.
It looks like there's no questions in the chat, so I guess we can end a little bit early or on time.
Yep, right on time. Perfect. Bye, everybody. Thanks so much.
Bye. Thanks, everybody.
Bye.